Until the pandemic came and hit us, I think a lot of people were not quite so aware as to how much our lives are impacted by global events that might start anywhere.
This is a real crisis.
I mean, it's been clear that this was likely to spread in the US.
We need to be thinking much more ambitiously.
Climate finance is a very big issue.
We, the Center for Global Development, we're a group that try and see how we can make the international system that supports global development work more effectively.
CGD came about because it was time to focus not only on what developing countries should do, but much more on what the rich world should do.
How do we finance infrastructure in the poorest parts of the world? How do we increase productivity in agriculture? What kind of policy brings out the best outcomes?
Some of our previous work has helped to come up with a kind of innovative financing mechanism that was used to help launch pneumococcal vaccines. We really have researchers and experts here at CGD who come at these issues from multiple vantage points, and I think that's just what helps make our research more rigorous, more rich, and actually more connected to the realities that decision makers are grappling with.
We've been looking to CGD for all of your research and analysis to guide us.
So CGD is nonpartisan. Because of that, over the years, that credibility has given us significant convening power.
Our government highly values the work.
What CGD is about is you can ask those difficult questions that people refuse to ask and actually find solutions.
We're thinking about how climate change will impact migration patterns, how that will in turn have impacts on people's health.
It's challenging to be able to align budget with ambitious programmatic goals, but it can be done.
Every single time that we're able to get it right, it means we're reducing significant poverty.
If you can help to make things a little bit better, that's a good way to spend your time.
Welcome everyone to the CGD event. Achieving UHC requires disinvestment as well as investment, the experience of Malaysia, Iran and Uganda. My name is Pete Baker. I'm a policy fellow and a deputy director of the health program here at CGD. I'm particularly excited to be discussing this important but perhaps challenging topic today of looking at how disinvestment is such a critical part of achieving UHC. I guess if you look at the context right now, looking back to 2022, was probably the year when many of us were thinking about how we can get over the COVID pandemic, how we can build back better. However, I think 2023 is perhaps posing a different challenge to many countries right now. Many countries are going through economic crisis, fiscal crisis, and perhaps even debt crisis. UHC and SDG goals themselves are now becoming under threat. This is the reality and the difficult context we're facing in 2023. Here at CGD, we're very committed and convinced that bold, transparent, explicit priority setting using the best evidence and through strong institutions, through that it is indeed possible to achieve these UHC goals. But to do this, we're going to have to tackle this difficult taboo. We're going to have to look at taking away or disinvesting or reducing access to some services that the population currently enjoy. This, we think, opens up the possibility of freeing up resources to focus on the highest value impact and highest impact services. This is not to save costs as such, but is to enable the system to save the most number of lives, given tight budgets. Today, I'm excited to introduce a panel of experts to discuss both the kind of complex practicalities of this idea, but also the difficult political economy of this thorny but critical issue. I will introduce each one of them one by one to save time, and they'll each talk and give their initial reactions, and then we'll have a good discussion and debate around how it can be done. Please submit your questions as usual via Twitter or YouTube. So I'd like to kick off without any further ado to Hanin, who is a PhD candidate at the University of Glasgow and was previously the Senior Principal Assistant Director in the Ministry of Health, Malaysia. Hanin's going to talk about a scoping review she's completed recently on this exact topic, but also give some insights from the Malaysia experience. So Hanin, thank you. Over to you.
Thank you, Pete, for the kind introduction. So, hello, everyone. My name is Hanin Kamaruzzaman. I'm a PhD candidate in HETA, University of Glasgow, and also a Senior Principal Assistant Director with Malaysian Health Technology Assessment Section, Ministry of Health, Malaysia. So I'm going to bring you through the landscape of healthcare disinvestment and sharing some experience from Malaysia. So do we have the slides on? Yeah, okay, nice. So basically, this presentation is mainly based on our scoping review on disinvestment in healthcare that was published last year. So next, please. So we know that health systems across the globe are recognizing that in ensuring the efficient delivery of care, it is important to complement investment in new healthcare technologies with strategies to reduce the use of ineffective interventions. These strategies, known as disinvestment, is a growing priority for international health policy in maximizing value and improving quality of care. Numerous studies on disinvestment have been published, describing processes at various levels. However, the success of these initiatives has been mixed, with less than half of the studies reporting the reduction of low-value practice. The global COVID-19 outbreak has forced many countries to spend a significant portion of their resources to managing the pandemic. Therefore, we think that promoting active disinvestment is timely to re-strategize value-based resource reallocation and also in aiding economic recovery. Next, please. We conducted a scoping review to map the available publications and studies related to disinvestment in healthcare. So in this review, we identified at least 34 disinvestment initiatives across 16 countries operating at various levels by different agencies. Among the programs implemented internationally, the most quoted is the Choosing Wisely campaign, launched in 2012 by the American Board of Internal Medicine and adapted widely since then. The majority of national level programs fall under the responsibility of the HTA agencies in that particular country. And however, the most of the initiatives discussed in this review are mainly implemented in developed or high-income countries. But we do acknowledge that we may have overlooked unpublished or informal initiatives in low and middle-income countries, which equally struggle with healthcare spending. Next, please. In many situations, disinvestment is frequently associated with budgetary concerns and affordability. However, it can also be prompted to enhance efficiency and quality of care through reformation of service provision. From our analysis, the purpose of disinvestment can be grouped into 4 themes. The first one is to enhance value-based spending. Second, for resource reallocation. Third, to improve quality of healthcare. And fourth, to inform policy making. Clarifying the purpose of this investment would help people to understand that it is a tool for improving access to high-value care and not for eliminating technologies and withdrawing resources on a large scale. Next, please. Now let's talk about the processes in disinvestment. So in general, disinvestment process includes identification, prioritization, assessment or reassessment, decision and dissemination. So in identification process, 3 important components are triggers for identification, source and implementation of the process. It can be done based on the input from clinical experts and program managers if there are conflicting practices with CPGs and variations in care. Implementation of identifying candidates for disinvestment can be done as an ad hoc or embedded methods. Ad hoc methods of identification usually are not carried out on a regular basis. Most of the time, it is reactive in nature as requested by other party or stakeholder. For embedded method, the identification process is performed routinely alongside other organization activities. The common prioritization criteria are the evidence on effectiveness, cost-effectiveness and safety of the technology, existence of available alternatives, the cost and disease burden. A specific tool for prioritization, the PRITEC prioritization tool, developed by Galician Agency for Health Technology Assessment, is a 3-domain weighted exercise with a score system that allows for the ranking of disinvestment candidates according to a set of specified criteria. So next, please. Next, we go into the assessment process. For the assessment process, common tools used are program budgeting, marginal analysis or PBMA, and health technology assessment or HTA. However, it is argued that PBMA is usually used to assess the distribution of resources for health services within a fixed budget plan, while HTA is mainly focused on single technology appraisals and is not specifically intended for disinvestment. For the implementation of disinvestment decisions, it may result in one of these 4 conditions. The first one is a change in application or scope of use. Second, full or partial resource withdrawal. Third, complete removal from practice, or fourth, no change to practice at all. Having said that, the impact of these decisions on resource withdrawal must be evaluated for their influence on patients' health based on the clinical effectiveness and the availability of the suitable alternative. And for dissemination, so active dissemination are commonly done through online or printed materials, HTA reports, commissioner guides, clinical guidelines, and journal publications. It can also be disseminated through conferences and making direct changes to formulary or reimbursement listings. A more passive dissemination include publishing the recommendation lists on websites such as Choosing Wisely or as a short reports. The next, please. Now we talk about the stakeholder involvement. The roles of stakeholders were described and discussed mainly in the context of the processes, facilitators, and barriers of disinvestment programs. Stakeholders usually involve our clinicians and care providers, clinical and political decision makers, patients, researchers, health economists, and public society. The participation of a diverse range of stakeholders is a critical factor in increasing acceptance. Various dissemination strategies were also customized to relevant target groups, making the information more acceptable and comprehensible. Next, please. Now we look into the challenges in implementation of disinvestment in healthcare. So the first one, we talk about the perception barriers. So healthcare professionals often perceive that removing an existing health technology is harder than refusing to accept a new health technology. Changing existing technology or practice may not be favorable since trained doctors view technology as an integral element of their job. For fear of being questioned by patients, some doctors are reluctant to discontinue legacy therapies such as older drugs, which have never been evaluated for cost effectiveness before. Another reason for refusal is the assumption that disinvestment reduces prescriber and patient choice. Next, moving on to the technical or scientific barriers. So in some, in some circumstances, the absence of robust evidence to support withdrawal decisions hinder the acceptance of disinvestment. For example, a joint NICE Cochrane pilot found that a specific review method, such as Cochrane systematic reviews, were more likely to establish an absence of evidence rather than evidence of a lack of efficacy or effectiveness. Furthermore, a variation in criteria for selecting and prioritizing health technologies for disinvestment can create confusion. Last but not least, on the organizational challenges, the stakeholders frequently lack the political, administrative, and clinical will to support these investment initiatives. There is often a reluctance to allocate resources to these investment programs, such as in training and financing for research to cover data shortages, as well as providing incentives for implementation and monitoring of these programs. Next, please. Now we'll talk about some of the Malaysian experience, although we are still in the early phase. Next, please. So in planning phase, the initial step to explore potential implementation of disinvestment activities started in 2019. We had series of workshops under WHO consultation, focusing on identification process of reassessment candidates. These workshops were also part of multi-stakeholder engagement. In this workshop, we look into the sources for identification of candidates for disinvestment. We are looking into reviewing CPG and HTA or technical reports for health technologies that are not being recommended. These documents are evidence-based guidelines and reports, so we think it would be a good start for identification process. We also rely on clinical experts, regulatory agencies, and proactive search from international network and also databases. From the prioritization criteria based on the stakeholder engagement back in 2019, we are thinking of using a similar criteria to PRITEC tool, looking into population or users, risk and benefit, cost, organization issues, and other implications. At that time, we were thinking of using HTA as a tool for reassessment of low-value care and health technologies. And then we started with spreading the awareness to the hospital director. So we start last year in July 2022. So we had a hospital director summit, so in which we conducted a workshop with the hospital directors to introduce the concept of value-based priority settings and resource allocation. And in this workshop, we use a PBMA exercise for investment and disinvestment of service and care provision at hospital level. So our aim is to promote awareness on available method for wise spending of resources. And it turns out that the hospital directors had a good understanding on the value of investment and disinvestment. So we concluded with that value of implementation should maximize the benefits, and value of disinvestment should not compromise the access and quality of care. So we have some next projects in the pipeline. We are thinking of getting the perception, expectation, really look into the criteria used, facilitators and barriers implementing the initiatives. So we are planning for the online survey with healthcare stakeholders on disinvestment activities in Malaysia, particularly at different level of governance, national level, regional, local, or facility based. So, and we will proceed with the interview with the key informants. Next, please. Another example is a medicine optimization program using a multi-criteria decision analysis on MCDA for formulary listing and delisting of respiratory inhalers. So in this exercise, the identification and defining criteria were based on the HDA framework, and suggestions were made by the Therapeutic Drug Working Committee. So in this exercise, 27 medicines were evaluated, and one newly listed and one to be delisted. Others remain unchanged. However, the committee did not recommend complete removal of any listed chemical entity, with the reasons that they prioritized to conserve the clinical freedom for prescribers and maintaining the patient access to existing medicines based on the principles associated with personalized medicines, individualized treatment, and mutually agreed to tailoring of treatment. Next, please. And finally, for our reflections, I think if you want to incorporate disinvestment as part of health policy, it suits well into the principles of any health policy implementation. In concern of time, I will leave you with summary of our disinvestment implementation in healthcare. Maybe we can come back to this during the Q&A session later. So the first one is on awareness. So there must be a mutual awareness that low-value care that provides no net benefit in specific clinical scenarios remains one of the most pressing problems in healthcare. B, on the budget sensitivity. We have to know the budget or resources, where it comes from to pay for the health services, and also we should know how it is spent. C, on the cost opportunity or the cost of inaction. For this investment, we should not only showing the cost saving resulted from the disinvesting of low-value care, but also the cost of inaction of not pushing for the change. And next is the fourth one is data. So data and evidence, I quote, data is the electricity of 21st century. So I think, like it or not, we have to look into the ways of handling the data, a lack of data for disinvestment purposes. Fifth, on the engagement, stakeholder engagement is the most important aspect. And I think it should be started early. And last but not least, the follow-up. We acknowledge there are limited information on monitoring of the implications of disinvestment decisions. And I think this should be looked into further. So next, please. So I think that's all. I would like to take this opportunity to thank these 4 brilliant people that have been helping me with this presentation, my supervisors, Prof. Olivia Wu and Dr. Eleanor Grieve, and some colleagues from MATAS, Ministry of Health Malaysia, Dr. Izuna Mutla and Kuno Hasni Abdurrahim. Thank you, and back to you, Pete.
Thank you so much, Hannah. That was a fascinating presentation, both of your review and the Malaysia experience. And just a few takeaways that I picked up on, just for interest. I heard that most of your research, or most of what you found, was high-income country-based evidence. So that's interesting for the lessons here today. I was also taken by your PBMA point. I think PBMA is an area that we don't talk about very much and is worth further consideration. I liked how you talked about the range of purposes and being clear why you're disinvesting before you started, and there was different options for that. And it's not all about cost cutting, as many people think. It can be about having the best impact for your limited budget. You kept on stressing the importance of stakeholders, which is so key given the resistance here. And I liked how you broke things up in terms of perception barriers, technical barriers, and organizational barriers. I think that's a really nice structure that hopefully we'll come back to later. And I definitely agree with your 6 reflections, including the importance of knowing the cost of inaction, because we don't talk about that very much. Like, if you don't disinvest, what's going to happen, like how many lives will be lost because of not disinvesting. Okay, so thank you. So let's, Parisa, I think that your connection seems to be working, so welcome. Parisa is the head of Secretariat for the High Council for Health Insurance in Iran, and will be telling us about the health benefit package experience there. Over to you.
Okay, thank you. Would you please, at first, I want to say that achieving UHC requires disinvestment as well as investment. So I am Parisa, the head of the Secretariat of Council for Health Insurance in Iran. And I want to start my presentation next, please. Okay, the health insurance benefit package revision aim was redesign the health insurance benefit package. At first, 6 disease area, and including 30 condition, as you see here. MS package revising was the first condition. We decided to revise because of some condition this disease has. Next, please. Okay, if you can make it bigger, zoom on it. We follow 6 steps to revising the MS package, benefit package. At first, I have to say that we follow our work was based on ADP methodology, evidence-informed deliberative process, which was the help with our WHO consultants. At first, we established the committee as the ADP process suggests, then defining these criteria, select services for the evaluation, which result in MS for the first package revising. Then in the next step, we scoping, assessment, and appraisal. In scoping, we present some conditions, and after discussing about it and having review, we choose one, or we choose a condition. Then in assessment, based on HTA analysis and budget impact analysis, we choose a condition, then presenting appraisal session. We have done these 3 sub-steps for every single services. Then in communication and appeal, we publish all materials have achieved from the previous session, and then in appeal session, we analyzes and review all feedbacks and comments we have received from the communication. Sorry for internet issues. After it, we monitoring and evaluating our achievements. Next, please.
Parisa, I think we may have lost you again. Can you hear us okay? It's a shame, because just getting to the exciting part where we hear about how Iran did accept some for inclusion, as you can see on the screen. But I think more than half of the technologies were not accepted, and one was conditional. Parisa, can you just waiting to see whether you can hear us, whether you're able to rejoin? Okay, I think we should probably move on to Sergio then, and we can always come back to Prisa afterwards for the second half of her presentation. So Sergio is a research fellow at the Faculty of Health and Policy at LSHTM that's been working on a project in Uganda that's going to talk about it as a nice case study of disinvestment. Sergio, over to you.
Thanks, Pete. Let me just pull up my slides. Can you see them there?
Not yet, but maybe there we go.
Great, thanks, Pete. So yeah, I was going to talk a little bit about a case study on disinvestment in Uganda. Just as a bit of background, for those of you who as many of you may know, Uganda is in the top 10 of countries with the highest HIV prevalence in the world. There's around 1.3 million people living with HIV in Uganda, of whom about 70% are in antiretroviral treatment. Uganda adopted a test and treat policy in 2018, meaning that everyone who tests positive for HIV is put on ART right after. The last 5-6 years have coincided as well with a period of decrease in international funding to meet HIV targets, so less donor money, which has increased the need for local funding for the HIV response. So what is cotrimoxazole? Cotrimoxazole is a broad-spectrum antibiotic. Before there was ART widely available in sub-Saharan Africa, the WHO recommended daily cotrimoxazole preventive therapy for people living with HIV because it reduces HIV-related mortality by dealing with bacterial infections and malaria, but also causes adverse events, in this case, hematological events like anemia. After ART was widely available in Africa, WHO's recommendation continued to be to maintain daily cotrimoxazole prevention therapy in the basic package of care for people with HIV for additional protection in settings with high prevalence of bacterial infections and malaria. But these recommendations were conditional on context-specific issues. So fast forward to 2011 to 2014, a randomized controlled trial called COSTA was carried out in Uganda with HIV-positive ART-stable adults. The trial had as its purpose to understand the effects of discontinuation of cotrimoxazole. It had two arms. In one arm, people continued to receive cotrimoxazole, and the other people received a placebo. Just very quickly, the trial showed that in the arm of people who did not receive cotrimoxazole anymore, you saw an increase in bacterial infections, mostly pneumonias, but a decrease in hematological events. So you end up with a situation where you take this drug away, you have more bacterial infections, fewer anemias and things like that. So what is your policy decision? So they asked us towards the end of the trial, as the economists, to come in and do an economic evaluation of the cost effectiveness of discontinuation of cotrimoxazole. So what did we find? We costed and we looked at the effects. We costed the distribution of cotrimoxazole, any cotrimoxazole preventable events, any side effects, and malaria. We found that in the placebo arm, costs were lower because even though there was an increase in costs in terms of treating bacterial infections and malaria, the cost of delivering cotrimoxazole itself was quite high. So in fact, the costs in the placebo arm were $17,000 lower than in the cotrimoxazole arm. We did, however, also find that removing cotrimoxazole led to more DALYs, right? So that you would expect. You remove the drug, you get less health as a result. So you lost 26 DALYs in between the two arms of the trial. So what you ended up with there, taking away cotrimoxazole, that intervention was seen as less costly but also less effective. So when you plot that in the cost effectiveness plane, you find that it is in the southwest quadrant. And here we had a DALY an ICER of $744 per DALY averted, which is not cost effective by any of the thresholds that we looked at. So basically, when you flip it around, taking away cotrimoxazole is indeed a cost effective intervention because the money that you are saving can be invested in other interventions that produce more health. So how does that fit into the policy decision and implementation? So I'll say that up to that point, to what I've explained now, we were part of the research that informed the decision. What I'm presenting now is more anecdotal and what I know happened afterwards. So the Ministry of Health of Uganda was in the process of updating their HIV treatment and prevention guidelines in 2017 and 18. Amongst the body of work that they reviewed were findings from the cost of trials, as well as other global evidence on cotrimoxazole preventive therapy. Towards the end of 2017, we were asked to present the results of the economic evaluation. They were well received, understood, etc. And sort of put this out of my mind for a few months. In the middle of 2018, colleagues in Uganda pointed out that the media was reporting stockouts of Septrin, which is cotrimoxazole, and that newspapers were reporting this in quite strong terms, saying, for example, thousands of patients find themselves exposed to potentially life-threatening infections. And in the media, cotrimoxazole was mistakenly labeled as an antiretroviral drug instead of as a preventive antibiotic therapy. The reaction was strong enough that it merited a clarification from the Ministry of Health that sort of restated the position that they were reviewing cotrimoxazole, but no decision had been made on discontinuation. But a few months later, in September 2018, the new guidelines on HIV and AIDS were published, and indeed, cotrimoxazole was not discontinued for everybody, but largely restricted, only to certain groups of people like pregnant women or those having treatment failure. So again, there was a big response from the media about the lack of access to cotrimoxazole. Patient groups sued the government over lack of access to the medication, citing violation of the right to health, which is in the Ugandan constitution. And there was a call for greater sensitization and for greater debate about why cotrimoxazole was discontinued. So just this makes me think about a few points that I think we can discuss as a group that could be interesting, is that policy decisions do not happen in a vacuum. In the case of Uganda, it was very interesting that you had these stockouts that were unrelated to the decision to disinvest, but they coincided with the decision. So the issue became very fraught from the start. This example also shows the importance of conveying accurate messages. A stockout is not the same thing as evidence-informed decision to discontinue, and ART is not the same thing as cotrimoxazole, but these differences need to be explained properly, and they need to be believed by the people who receive the medication. Something else that came up during these meetings with Ministry of Health was that it was essential to consider health systems constraints and a societal perspective. Discontinuation may be cost effective, but is the health system set up for dealing with the consequences? So in Uganda, is the health system set up to deal with more cases of malaria, more cases of bacterial infections? And also, who picks up the additional costs? Where ART is provided for free, cost of bacterial infections, malaria, etc., may not be, and so it will be the patients who will be picking up those costs if they do end up suffering from these illnesses. And the last point is that trust is an essential pillar in the health system. You see that episodes like this can disrupt trust in the health system if there's not proper communication. And I think the effects of that discontinuation, that loss of trust, need to be thought through in the long term. And I think that's all. My email's here if anybody wants to ask any questions.
Thanks, Sergio. Really nice case study. You summarized it nicely at the end. A few things I heard in cases of interest. I heard the importance of the wider political context there, the policy context, and it's not, like you say, it's not in a vacuum, because in the end, this is going to become a very political matter, taking something away from people. That the interesting issue of fragmentation of health financing, meaning that disinvestment doesn't necessarily save money for the right decision maker. It might not save money for the right people, and so some people may then complain that either it falls on their out-of-pocket expenditure or it falls on a different payer. And the importance of trust, which is key here. So you're going to take something away from people. People have to really believe that you're doing it for the right reasons. Good. Breeza, I think great. Breeza's back online, so let's hand over to you, and then we can have a panel discussion about all these fascinating issues. Thanks, Sergio. Back to you, Breeza, if we can hear you.
Presenting here. Technical this we also I mean, hard.
Okay, I think we've lost you again, Priza. We'll just wait briefly and then we'll move on to the discussion. Okay, can we bring down the slides, please? Let's move on to the discussion. Sergio, just one other reflection that I just wanted to hear your response on, if that's all right. You mentioned the kind of rights-based angle. Was that a big part of the Uganda side? And should we expect that rights-based systems that have, the right to health are going to find disinvestment particularly difficult? Or was that just a tool used by campaigners?
That's a good question. I'm not sure. And the problem is, one of the great regrets in the study, we were burdened for the economic evaluation. So a lot of what we found out after, we couldn't study systematically. We didn't have ethics to do interviews. And anyway, so this sort of sparked my whole interest in this topic, this working in this economic evaluation. But I think one of the things that I remember hearing at the time was that there was an application for global replenishment. And so they were redoing calculations on the HIV program, and they were looking at the expansion to universal ART coverage. And I think they sort of had this trade-off in saying, well, we think cotrimoxazole is very costly. The trial didn't show any differences in mortality. So if it costs more and there's no additional deaths, we would rather use that money to ensure that everyone has coverage of ART than receive this prophylactic antibiotic. So in some ways, I think that I don't know whether explicitly the rights-based issue was how far it was pushed by campaigners, but I think it did come into the debate in the sense of how do we best make use of HIV resources across the country.
Nice, thank you. Priza, let's try one more time, and otherwise we'll do a discussion. So Priza, over to you. Thank you for trying.
Okay, you can follow the link on the before slide to see the whole article. Now here is the result of the revision. Next, please. Okay, new MS package implemented nationally from September 2021, and now the project on revising monitoring and evaluation on it is on process now. And you can see the items here, which are be under monitoring and evaluation. Next, please. Okay, the lessons from this revise is here, presented here, but two points are important in.
Oh no, that's a shame, Priza. I think we lost you again. I was lucky to see these slides in advance. I mean, she's about to join. One thing I took away from here was that disinvestment within a certain disease domain may actually be easier. So trying to attempt to do the whole health benefit package and cut the best thing across the whole board. Cut the thing of least value, as it were. The best thing to remove is quite tough, because then you put the cardiologists against the gastroenterologists or whatever. You put whole different groups against each other. Whereas just sitting down with one group with similar patients and similar specialists allows you perhaps to deal with the political economy more in an easier manner. And that's what I took away from that final point. I'm not sure if that's exactly what they found, but and being clear on the budget and using deliberative processes, of course, to try and show that you're Priza, can you hear us?
Yeah. I just want to think that conditional coverage and application was invest in MS package benefit package. I think.
Nice, thank you. Okay. Is there any more slides, Priza?
Thank you.
Thank you very much. Apologies for connection problems. Okay. Let's take the slides down. On that last point, actually, if you look at Hannon's review, one of the studies mentioned there talks about that it may be better to try and reduce, replace, or restrict access to a service rather than to go full for disinvestment and removal of a service. It may be more politically acceptable, more easy to implement. But okay, Hannon, back to you as a first question, if you don't mind. I'd like to hear a bit more about the Malaysia experience. I think people would find that interesting. The first part, I wonder if you could say a bit more about the aim and the purpose. What was the motivation behind that? And maybe some more about the barriers and resistance you found. And then on the second part, you talked about this kind of Malaysia didn't manage to change much. I think it was only one medicine that got changed and it wasn't fully taken off. So after all that work, I wonder if you could say a bit more about why it wasn't taken off, or maybe also what could be done next time to be able to follow through with the plan. Thanks.
Okay. For the first question, I think the aim and the reasons why we started doing the training for the disinvestment and health technology reassessment back in 2019 is because at that time we have a demand to look into the health technology life cycle, because as a HTA agency in Malaysia, so we work towards the health technology life cycles and how to manage health technology as well. So it started with the stakeholder engagement to fine tune the criteria initially, but we were thinking of perhaps the next year we can do this. We start with the plan that we have in mind, reviewing all the recommendations from the CPGs that we have, and also the HTN reports that in terms of the do not do recommendation. However, COVID happens, and then something has to stop. So we take a break a little bit, and then right now we are refocusing on perhaps re-strategizing the criteria that we are looking into. And then I think the initial step that we did was to create the awareness among the stakeholders, and the stakeholders that we choose is actually the one that are familiar with the health technology assessment. So now that we are going back to start looking into the engaging more stakeholders, a wider group of stakeholders. So we think that hospital directors, program managers at Ministry of Health levels, they are the one that knows better what's in the list of to-do list, or what should be disinvested. Because I think from my opinion, from my experience looking at reading all the articles and then looking at the how disinvestment programs or health technology reassessment initiatives being taken out in certain countries, I think the implementation or the tools that are being used could be different at different level of governance. Maybe at national level you can do it, HTA, but at the facility-based level or within the fixed budget plan, maybe you should use PBMA, program budgeting margin analysis, because it looks into how you spend resources, and it looks into where are the areas that we can reduce or we can improve the spending of resources. And even having said that, I think even the PBMA has its own limitation. So I think complementing it with other tools, for example, using MCDAs, is something that we are looking forward as well. So so the next question would be, what's again? Come again?
So,
the barriers, right?
Sorry, which one?
The second question.
Yes, about the one technology, the one drug that was considered and was only partially removed from the list, and perhaps how to build that coalition to be able to make sure that happens next time.
Okay, for the medicine, I think one of the examples that I put up on the medicine optimization program, so that one was done by the pharmaceutical services division. So they were this activities are published in 2021, but the activity itself was happened in 2018, 2019. So the reason why it is not being the decisions to, even though it's proven to be worth doing what they listed, but the committee at that time, they prioritized to conserve the clinical freedom for prescribers and maintaining patient access to existing medicines. So they were they were holding to the principles of associated with personalized medicine, individualized treatment, and mutually agreed to tailoring of treatment. So I think perhaps for me, I think because that's one of the examples that I've come across. I think the reason why there are still reluctance of that is because of the awareness the understanding of what happened, the understanding of if you still put the list or the drugs in the list, people still will be using it, and it will jeopardize the chance for the better drugs to be in. So I think, you like it or not, the awareness should be high among the prescribers, especially.
Yes, excellent. Thank you. Priza, can I just check? Can you hear us? Okay.
I can hear you.
Good. I just want to hear a bit more, if you're able to, about the barriers and opposition you faced in some of this work in Iran.
Actually, we use Asian method and the challenges and barriers impact. So we all have the challenges with.
Okay, looks like that we still can't hear Priza. So Sergio and Hannah, we've talked to both of you. We talked a lot about stakeholder management and the importance of stakeholders here. But we often talk about that as kind of a barrier that have to be managed. I wonder if there's a more positive way of thinking of this. Like, how do you create like a coalition, or have you any experience, Sergio, perhaps from Pakistan or Uganda or other places you've worked, and Hannah broadly about that idea? Like, how do we make this into a positive thing that people are working towards optimizing the health service, rather than constantly a kind of negative thing of cutting and stakeholder management? Who would like to go first on that? Go for it. Oh, please, if you can, yes.
Sorry, I have your voice breaking, but I want to talk about the process. The technical group, and then they and members of my council to their approval. This is to actually to make satisfy them in terms of budget limitation.
Okay, Hannah, can I push that question back to you then? Sorry, okay. on forming more of a positive coalition for this.
So I think because we acknowledge that stakeholder involvement is the most important and most crucial things. If you do advanced analysis, if you do a complex analysis, but the implementer is not willing to take it, then it's no point. So I think the most important things is the meaningful engagement may be strengthened with continuous stakeholder participation and transparency in methods and processes for decision making. So most importantly, they must be included from the early phase of the planning itself, because this investment should result from a reasonable, open and justifiable process with fair consultation. So the first thing, I think the need for this investment must be demonstrable. So we can't think of implementing this investment just for the sake of having an activity within the organization. It doesn't work that way. So I think I've just started with some online stakeholders. So when online stakeholders survey with some of the stakeholders in Malaysia, so the most important, I think, the most striking barriers that they were talking and they were conveying to me is that the Ministry of Health, for example, is trying to implement programs, but the training was not there. It is not having incentives, but the consultation or what to do next is not there. So I think, rather than looking at the disinvestment up to decision alone, then the monitoring of it must be continuous as well. So you can't do up only the decisions and then you just let it be. You don't know what happened after that. So I think as much as important to have the good methods, you have to have the good implementation or monitoring system as well.
Nice. Sergio.
It's a good question. I mean, I think from an outside perspective, as someone who's sort of an analyst of these processes, I think the thing we forget as health economists is that optimization is not the only thing that's been considered, or in fact may not even be the most important thing considered. And I think stakeholders have other priorities. And when it comes to things like health benefit package design, they are sort of juggling, yes, optimization, but also probably equity and dealing with how does this affect patients and their costs, and how does this affect all sorts of other things, right? And I think it's easy to think, well, the thing that is least cost effective, we can just kick out of the package to make more room. But I think there is other stuff going on, and I think we're not very good at measuring these other things. We, as a sort of discipline, we know a bit of cost effectiveness, ICs, all that stuff, but I think how we understand these other motivations or these other decision criteria is probably less researched. So I think maybe just starting from a point where an understanding that stakeholders have these competing priorities and these competing values, and that it's important to sort of maybe research that more.
Nice, thank you, Sergio. From an analyst perspective, then, were there elements of the technical work that you found, or the way you designed it, that actually helped to make it easy to understand for policymakers, or are there elements that you would do differently next time to make it more implementable?
Yeah, I was interested in sort of people in the committee who then spoke to me. So the two things that mattered to them were, does it cost more, and did people die? So this cost effectiveness thing, whether it's above or below a threshold, didn't really matter that much. They just think, if no one else is going to die and this costs us more, let's get rid of it. It was that simple. But they did express concern, and they asked me repeatedly about this. Was A, can the health system cope? And I said, well, I can't tell you, but I think given that we did some probabilistic sensitivity analysis, I think probably yes. But B, how are we going to deal with people who cannot afford then to be hospitalized for malaria or for whatever else they're going to get now because this drug was discontinued? So if I could do this again, I would try to get in on the beginning of the trial, not just at the end, but also, try to include patient costs and try to do more heterogeneity, try to understand heterogeneity more within the Ugandan context.
Nice. Thank you. Hannah, whenever we're doing proactive setting support work with countries, we often think about whether there's a policy window or a kind of imperative to do something now. I guess with disinvestment, probably that comes up mostly with budgets being strained or something. In your review, did you find that as an important factor? Like, was a policy window or something at a very high ministerial level happening? Was that key from the studies you looked at, or was it more like the deliberative processes and stakeholder engagement that you picked up on? Oh, I can't hear you, Hannah. Maybe I don't know if it's your side or mine.
I think for the most of the researchers in disinvestment itself, I think disinvestment is viewed as something negative. So people don't want to talk about it that much. But I think we are the one that will have to change the perceptions that this investment is not for cost saving. It is not to stop funding things just because we don't have much money, but it's more on the quality improvement initiatives. So we have to be make other people know that it remains one of the most pressing problems in healthcare because it raises costs, actually. It causes iatrogenic patient harm, and often it interferes with the delivery of high-value care. So starting from this awareness, the acceptance will be less difficult. I think in the policy window, in Malaysia itself, I think in Malaysia, we don't have specific or explicit benefits package. So it's quite hard to propose the idea of disinvestment. So what we do is that we started with the HJ organization because we think this is the most people listen to us. People listen, the policymakers listen to us. The problem is that whether they understand what we want to convey to them. So the communicating this evidence to the policymakers would be challenging, especially for disinvestment purposes. I think there are some works that we need to do still, but I still think that there are bright future for us.
Nice, Helen. Parisa, I want to give you a chance to provide any reflections on what you've heard so far, if you can hear us.
Well, what about, may I talk? Yeah, I have
Yes,
you.
please go. Mm-hmm.
I generally wanted to talk about our experience. I think that ours is one of the most successful experience because we have we have revising all potential and included services and interventions for MS package, and then the quality of weighting to quality of care and sustainability and necessity help to our stakeholders and technical team and committee to investment and disinvestment for the interventions, and they can reallocate for the services and what is included in its benefit package. Because of this, we make less the residents and prevention of, the patients association and the society impact, because we didn't disinvestment any care or any intervention from the MS package or other condition package to cover the new interventions. So maybe I think that that was the smoothest way for this investment if you consider reallocation and conditional coverage for your country.
Thanks, Priza. So it is great to have such a strong example of it working. And I like the fact that you're drawing out the factor of conditional coverage, which I think you mean to like really focus the technology on the best indications and the best populations. Is that right? Is that what you mean by conditional coverage?
Yeah, because we have budget concentration and we have society pressure very much. So the best way we choose that was to reallocate instead of disinvestment totally.
Yeah.
Yeah.
Are you able to say anything about who was driving this and who was supporting you in terms of stakeholders? How did you manage to make this a success in terms of building a coalition of support for you?
Actually, as I'm working in the Council for Health Insurance, the Minister of Health in Iran is the head of that council, and all basic health insurance organizations are the member. So the decision made in a very high level in the country, as well as we have the comments and feedbacks from the patient association and the specialist association for the MS condition.
Thank you, Priza. Okay, so we're coming to the end of the session. Hanin or Sergio, any last reflections you'd like to give before I wrap up?
I'd say this is an area where I think there's a lot of scope for research. I think, as Hanin says, there's very little written about it. There's very little in low and middle income countries. We're about to publish a bit of work we did in Pakistan. It was very preliminary, but it looked at the likelihood of disinvestment when interventions may be not cost effective but had high coverage. And unsurprisingly, we found that if you have high coverage of an intervention, it doesn't matter how poorly it does in terms of cost effectiveness, it's very unlikely that these interventions will get disinvested or will be removed from the package. So anyway, I think there's a lot of scope for analysts to look into this topic. So it's an exciting area of study.
Thanks, Sergio. Hanin?
Okay, I just want to talk about the data and evidence. I think I quote, data is the electricity of 21st century. So without data, none of the amazing technologies and advanced analysis can be used to assist decision making. So, and we have to admit that data and evidence is the currency to convey recommendations for policy making. So we need data to show that probably we are investing a lot of money in things that do not work. But the challenge is nobody wants to collect data on things that do not work. So mainly because it's not attractive, So only those with interest in disinvestment research will do that. But this will impact how the stakeholders make decisions, and this has to do with how clear the evidence are and whether the alternative practice is available as well. So I think maybe we have to look into the applying the real world evidence and data in this disinvestment rather than relying on the marginal cost effectiveness analysis alone. So maybe we have to use audit data. The databases that we have are also in some countries called as written. So all this must be taken into account for the analysis of disinvestment.
Nice, Hanan. Thank you, Sergio, Hanan, Prisa. It's been a fascinating conversation. We've heard about the situation in Iran and Malaysia and Uganda. I think we've heard how this is a very key area that's important for to be able to optimize UHC by disinvesting as well as investing. I think we've heard about the many challenges the countries have faced. It's not easy. I like the way you broke up it into perception, technical and organizational challenges that will help us, I think things through. We've heard that the policy window and context matters, and that high-level support, like in Iran, can really help push things through, I think. The overwhelming message about stakeholder inclusion and management is key, ideally through a rigorous deliberative process, and the importance of trust that I think comes partly from that, and the importance of data. I think that was a very nice last message you gave there. I think there may be easier and there may be harder options. So the easier options I think we've heard today are around focusing perhaps within the disease and perhaps choosing to restrict and reduce rather than to eliminate. I think that might be an easier option. And also I like the final point we made earlier on, Hanan, about being clear about implementation approaches. It's not just as good enough to make a decision that something should be removed, but really thinking through implementation, M&E, and then research on how countries have done as well is a key gap that Sergio pointed out as well. Okay, so thanks everyone. Have a wonderful day, and please share the link to this so others can watch as well. Take care.
Thank you. Bye.
Bye. Take care.